I'm watching.
This thing has come here again. Where's this funny thing has come here again on my screen?
Can you do the corner?
I
Get it.
Thank you. Okay. Okay, sorry, I had some technical issues, so we're going to start. Let me just start by apologizing. I know I sent in the, I uploaded the slides very late today, so I'm really sorry. Still having some teething problems with sorting out all these things. Hopefully from the next lecture, I'll try and make sure I get it at least a day before. Can you all hear me okay? No? I don't know how to increase this. So, is this better? Yeah? Okay. We're running late. We have quite a bit to cover today, so did anyone have any chance to review what we did yesterday? Or you're all busy studying for tomorrow's? Okay, I understand, sir. But did you get a chance to look at the thrombosis, the mechanism? No? Because the thing is, even though I'm not going to question you on what normal is, you have to know what normal is in order to appreciate what abnormal is. And the thing is that because we have a lot to cover today, much more than yesterday, I'm not going to have time to go into details with the review, so I'm just going to run through it because I thought maybe you'd just have an opportunity to glance through it. It's something you've done before, so I just thought I'll put it out there so that you can just read it and refresh your memory, because it will help you as we go on to the topics for today. So back again to objectives 3. Fluid and hemodynamic derangements. We did the first 3. So we're going to conclude by doing thrombosis, embolism, infarction, and shock. That little thing is there again. I don't know where it's coming from. Okay. So this was what I asked you to review, and like I said, I'm just going to rush through, and I'm not going to touch on everything. But basically, when it comes to hemostasis, there are 3 things you need to remember. The endothelium is very important. So these are the major contributors to normal hemostasis. You have endothelium, then you have the platelets and the coagulation cascade. And basically, when it comes to if you have a vascular injury, the first thing that happens is you have vasoconstriction, and it happens at 2 levels. There's the initial one that is driven by neurogenic reflexes, where you have a reflex vasoconstriction, but the predominant vasoconstriction is by a release of endothelin. So the release of endothelin causes that initial vasoconstriction. And then the next thing, so what the body is trying to do, the vessel is trying to reduce the amount of blood loss by, trying to constrict. And then the very next thing that happens is like the primary hemostasis, and that starts off with platelet adhesion. What causes platelet adhesion? When you have erosion of the endothelial cells, right? It exposes the subendothelial layer, which is where you have the extracellular matrix, collagen in particular. That's a very potent trigger for, thank you very much. It's okay, thank you. That's a very potent trigger for platelet adhesion. So you have platelet adhesion, then you have the activation of platelets, and then afterwards you have aggregation of platelets, and that forms the initial plug. And that's what is referred to as primary hemostasis. But the secondary hemostasis, it starts with the tissue factor. If you remember tissue factor is what? This is produced by the endothelial cells, and you know that it's part of what the coagulation cascade. That's what? The intrinsic pathway or the extrinsic? Extrinsic pathway, that's where you have the tissue factors, the extrinsic pathway. And so it sets up a series of, tissue factor is also referred to as thromboplastin or factor 3. And so in conjunction with factor 7, it now triggers the coagulation cascade. You have activation of thrombin. What thrombin really does is to help form a more stable plug by causing the breakdown from fibrinogen into fibrin. And so when you have fibrin, that's the more stable clot. Now, the most important thing, as that plug is formed, you don't want the plug to go beyond the area where you have the tissue damage. So what happens? You have a series of that is set in motion. So you have the weak plug that forms first, then you have the strong fibrin plug that seals the vessel. And then because you don't want it to go beyond that level, you have the release of blood thinners, the tissue plasminogen activator, and also the thrombomodulin. Thrombomodulin is involved in blocking the coagulation cascade, while the tissue factor plasminogen activator is involved in fibrinolysis. So it's in actually breaking down the fibrin, and so that you don't have the clot getting bigger and bigger. And usually when you have this fibrin clot, it traps red blood cells, and so that's how you have. So you're going to see that when it comes to thrombosis, you see that what you have is just an exaggeration of this response. For endothelial cells, basically, endothelial cells have, depending on what's going on, they have like different, they can either have, they have pro-thrombotic properties, and they also have anti-thrombotic properties, just like I explained now. They want, initially is to form the stable plug, and then afterwards is to inhibit it and prevent it from growing further. So we have the coagulation cascade. The most important starts with the tissue injury, where we talked about tissue factor that I just told you about, and I said is also known as thromboplastin, and the end result is to get to have thrombin, and which is involved in cleaving fibrinogen to fibrin to have that closed fibrin. So I'm not going to go through this, but these are, the endothelial cells are known as the central regulators of hemostasis. And so they have pro-thrombotic activities, anti-thrombotic activities, which are listed here. You can go through it when you have time. And then the platelets, they're primarily involved in just closing the small gaps. So when they're activated, they undergo conformational change, spread out, and then you have, they release their granules, and then you also have activation of more granules. And the most important are the alpha and the dense granules. And then, of course, you have the coagulation cascade, and the extrinsic pathway is much more important than the intrinsic. So let's move on to what we have for today, and which is thrombosis. What is thrombosis? It simply refers to the process of thrombus formation inside a blood vessel. So it's very important that you have, so when you're talking about thrombus, you're saying it's formed within the vascular system. So it's a solid mass of blood constituents that are formed within the vascular system during life. So their blood, it's a mass, it's solid, it's made up of blood, and is formed intravascularly. Why I put different during life is because the thrombus is more like an ante-mortem clot, right? So it's formed during life. Then you have post-mortem, which is after the person dies. So if you had to attend an autopsy, for example, and then you saw a blood clot in the vessel, how would you tell whether this thrombus was formed or this clot was formed while the person was still alive or formed after death? So that's why I'm kind of trying to differentiate it. For a post-mortem clot, so if you look at the pictures that I put there, the top one obviously is the thrombus that is formed, the antemortem clot. If you look at it, it kind of looks like almost like when you peel an onion, and then you look at the layers that you have. We're going to see as we talk more a little bit more about it, you understand why you have those different layers. For the post-mortem clot, what really happens, because it's more like a passive process, person has died, what just happens is that the red blood cells settle, and so you have two layers. This is what looks like I told you pathologists like to use food and things to, to remember. So this actually says it looks like red currant jelly, and then this one resembles chicken fat. It looks a little blood tinged, but it's supposed to have, so this is supposed to be so you have these two layers, where you have the red cells settling down, and then the other blood constituents just there, mainly the platelets and fibrins. So that's where you have on top there. So while this one, the thrombus tends to be more friable, it breaks up easily. This one tends to be a little more elastic. Okay. And then another thing is that for the thrombus, they form the postmortem clot tends to take on the shape of the vessel in which it was formed. Okay? So because it's just a passive thing, the person has died, relaxed state, at that state that the person is, that's how the clot forms. So you should be able to differentiate between what is an antemortem clot, in other words, a thrombus, and the fact that it's formed within a vascular system and separated. And then you'd also see that it's something similar when you take, if you take a blood sample from someone and then you put it in a vacutainer, and then if it doesn't have the things that prevent it from clotting, you're going to see that it's going to separate out like the bottom one into two layers, where you have the plasma on top and the red cell below. I think I have a diagram afterwards. Okay, so what are the major influencers? What are the major predisposing factors for thrombus formation? It's referred to as virtuous triad because that's the guy who kind of came up with the concept. And so you have endothelial injury, you have abnormal blood flow, and you have hypercoagulability. One of the things I need to stress, why I put that in the circle, is for you to realize that either of these things can initiate thrombosis. It doesn't have to be, all three don't need to be present. So you can have one, in certain cases you can have 1, 2, 3 all present. In some you can have 2, in some you can have just 1. So any one factor is enough to initiate thrombosis. Hypercoagulability is normally divided into genetic factors and the acquired factors. And for abnormal blood flow, so what really happens is with abnormal blood flow, you have two things going on, and that's turbulence and stasis. If you can imagine, like you turn on a water faucet, right? And water is gushing out. If you put an object in the water, it's going to, it's going to hit there and then it's going to splash to the sides like that. So you can imagine when you have a vessel, like where you have a bifurcation of the vessel. Normally, when blood flows, it's referred to as what? A laminar flow. And so you have what? What you have in when the blood is flowing in the center of the blood flowing through the vessels, what do you find there? Do you remember? Huh? So in the center, so when they refer to like within a blood vessel, in the center, you tend to have the red blood cells, and then you also have the platelets. On the outside of the periphery, still within the flow, that's where you have the plasma, the liquid. So the solid one is more like in the center, and then the liquid is all around it. So this plasma keeps the platelets and the red blood cells from getting in contact with the endothelium. And so you have that normal thing. But when you have some form of stasis, stasis, or you have like where you have, like I said, the bifurcation, and then you have flow getting to where you have the bifurcation, you have a little bit of turbulence because they're trying to find their way through one part or the other. And through doing that, they also create pockets of stasis. And through that mechanism, sometimes what you have is those are the areas that are more prone to developing thrombus. So in those areas or pockets where you have turbulence or stasis, you can have platelets contacting each other, contacting the endothelium, and then they trigger off the process of thrombosis. So what they do is they activate the endothelium. Remember I said that when the endothelial cell layers are removed, you have the collagen that is beneath the in the extracellular matrix, and that's what actually initiates the process of thrombosis. So also when you have reduced flow, you have dilution of the clotting factors. You have reduced dilution of the clotting factors because you don't have fresh input, and you also have reduced ingress of clotting inhibitors. So what you want is the inhibitors to stop the process, and then you want to dilute the clotting factors so they clear out from there. But when you have stasis, that doesn't happen. And so all these things kind of contribute to thrombosis. So what are the risk factors for thrombosis? Generally, they're divided into two. You have the genetic factors, and then you have the acquired factors. For the genetic, the most important is factor 5. Also, oh my goodness, sorry. Sorry about that. The genetic factors, which is due to, sorry, I'm just trying to get that. It's also referred to as lady mutation. Then you have prothrombin, and then you have increased levels of, so these factors are generally factors that are involved in encouraging or promoting coagulation. Okay, so when you have protein C deficiency, protein C and S, they kind of work in unison, and what they're basically involved in, they are antithrombolytic. They're more involved in the antithrombosis. They're the ones that are involved in limiting the thrombus formation or limiting the clot after it's formed. So if there's a deficiency of it, then you'd have increased risk of developing a thrombus. So, like I said, the factor 5, of all these ones, the one most important to remember is the factor 5. And it's usually, it's like, remember when I mentioned hypercoagulability, I said you have the genetic or acquired. So this is one of those hypercoagulability things. And what it actually does with factor 5, what happens is that the protein C, when it's activated, because factor 5 is involved in the process of the coagulation pathway. In those who have factor 5 mutations, what happens to it is that it makes it resistant to the protein C, and so when it makes it resistant to protein C, you can't have the breakup, you can't have the antithrombolytic thing, as effective as it should be. So it's about 2 to 15% of whites, and what you just really need to know is that there's an increased risk for venous thrombosis, almost as much as 50-fold increase, particularly when you have homozygotes. In other words, both alleles are affected. The acquired ones are the ones that tend to be a little more common, and these are things that you may identify with, okay, prolonged bed rest or immobilization, myocardial infarction, atrial fibrillation, tissue injury, cancer, prosthetic cardiac valves. So, and then the list. So these are all the two sets of things that I put, the high risk and low risk. They both increase the risk, but the ones on the left increase the risk a little bit more. So when you have prolonged bed rest or immobilization, remember what we said yesterday about the calf muscles helping to, when you walk around, you exercise, it helps to massage the veins and help to propel the fluid. So when you have someone who's been in bed rest for a long time, those dependent areas, you tend to have a lot of congestion and stasis. And when you have stasis, there's an increased risk for developing a thrombus. And then when you have myocardial infarction, what basically happens, we're going to talk about myocardial infarction, is that you have death of a tissue, that particular area, due to loss of blood supply. When the heart muscle is usually very muscular, when that part of the tissue dies, it heals mainly by fibrosis. When you have fibrosis, even though fibrosis, when you think of something as fibrous, it's tough. But it's tough, but what you want is something that can contract and relax to help pump blood. But it becomes, that part that gets infarcted becomes adynamic and doesn't contract as it should. So what you have is you now have stasis there. And when you have contracting and relaxation of the other parts of the heart muscle, because that part is rigid and is not expanding as the other ones, there's thinning out of that area, so you can easily have an aneurysm forming there. If you have an aneurysm, blood can pool there, it can rupture, and you can also have erosion of the wall and then trigger thrombosis. With atrial fibrillation, I think you're going to do that, a lot of those things when you when you start doing the systemic part. But it's just a type of arrhythmia, so it's an abnormal heartbeat. So sometimes you have heartbeats that go very fast, or it's very slow, or it can be kind of just irregular and all that. And so when it's irregular, it doesn't function as well. Remember, from the atrium, blood is being pumped from the atrium into the ventricle. So when it starts to misfire and doesn't function as well, you have stasis, blood pooling there. So these are just some of the examples. Prosthetic valves, you're putting something there. So remember, when you have something there, it's easier for you to have, I'm going to talk a little bit more about thrombosis, but you can see that it can create some degree of turbulence there, and that's what will increase the risk for thrombosis. So what are the sites that are predisposed to thrombosis? In the artery, the most common site, or the most common things that predispose, the most common things that cause thrombus to form in an artery is when you have an atheroma, which is you have atheromatous plaque, or if it becomes sclerotic, you start talking about atherosclerosis and all that, which is just you have lipid deposition on the surface, on the wall of the blood vessel. And so that creates some turbulence there. And then you can also have an increased risk for thrombus formation. For veins, remember, it's always, most of the time, it's due to congestion. You have slowing of the blood flow, there's stagnation. And so that's also a mechanism. And then another thing for vein is the hypercoagulation. So those are the main things that cause, predispose, or make it much more likely for you to have thrombus formation in the vein. In the atrium is the atrial fibrillation that I just discussed, that I said it leads to stasis. And then you also have mitral valve stenosis. If you remember, the mitral valve is what connects the left atrium to the left ventricle. With the heart valve, the most important thing is inflammation that is caused by infection. You're probably going to come across, by the time you go, I don't think you've got, I think that's also something you're going to do with Dr. Viggy, and that's when you talk about infective endocarditis, and that's how it's related to dentistry. So that one you just have to know that, but it's inflammation caused by infection. In the ventricle, it's most likely due to infarction, or you have an aneurysm in the ventricle. And then also you have the cerebral sinus. So let's look at a thrombus and just, this is an example that I gave for using the one when you have an atheromatous plaque, because that is one of the common causes of a thrombus. So you have the normal endothelium here. You have the subendothelial collagen. When you have an atheroma, what happens is that you have deposition of lipid here. And so you have lipid cells forming here. They create a kind of bump. So there's a stasis. Remember what I talked about, laminar flow. The blood is, the red cells, the platelets, they're usually in the center, the solid part of the blood constituents, and then the plasma is usually over around here. So when this intrudes into that space, you now have bumping, you have those cells like the platelets and all bumping into this. And with that turbulence that is creating there, what happens is that you have a loss of the surface of that, the surface of the epithelium gets, you have a denudation. So the endothelial cells are lost. It exposes this, and this is highly thrombogenic. It's, once it exposes the collagen here, that's what triggers off the whole process of thrombosis. So you have platelets adhering there. With the adherence of platelets, you have activation, and then it also causes aggregation. So you have more platelets come, and the whole process is repeated over and over again. So eventually what happens is, when you have the platelets, then you have the fibrin and the red cells on top, and then you have another layer of thrombus. So what you end up having is alternating layers of platelets, and then you have the red blood cells, the erythrocytes, and the fibrin, then the platelets, then the red blood cells. So that alternating layer of red blood cells, and then the platelets with the fibrin and the red blood cells, the alternating layer, that's what's referred to as the lines of Zahn, and that's what's responsible for the layers that you saw when I was kind of explaining to you about the onion ring that you saw on gross. So this is what I'm referring to when you say the lines of Zahn under the microscope. This isn't so. Here, this is where you have the red blood cells, and then here is the fibrin and the platelets that are more pale in color. This is actually the vessel, and you can see that this thrombus has almost occluded the entire space of the vessel. This is actually in the lungs, so these are the alveoli. If you look here, this is actually what I meant, like alternating layers. Okay, so you have, this is platelets with the fibrin, then the red blood cells. Here you have platelet with fibrin, red blood cells, and so on and so forth. So the fibrin entraps the red blood cells, and those are referred to as lines of Zahn. You don't see that in post-mortem clot. You don't see that when you take out blood. If we were to take a sample of blood and leave it to stand in a container or anything. So how is it different from stagnant clotted blood? Like I explained before, this is similar to when I talked about the red currant jelly and the chicken fat thing. And that's what happens when you put draw a sample of blood and then you put it in a test tube. You have the plasma, the white blood cells and platelets, and the red blood cells kind of like just there. So all the red blood cells separate. You don't have them in consecutive layers like you have here. So we're going to move on to how you would differentiate between an arterial thrombus that is formed in the artery compared to thrombus that is formed in the veins. Atherosclerotic plaques usually they form in the arteries or the aorta. They don't form in veins. So most times, whenever you hear of atheromatous plaque, just know that they're referring to the arteries. So it's the arteries that, so you tend to have atheromatous plaques forming in the arteries. And that's one of the major causes of arterial thrombi. Other things also, other major causes are like you have injury to a site, or you have vessel, bifurcation of the vessel. For venous thrombi, the most important cause is when you have stasis. Again, I keep stressing you have congestion due to valvular damage, and then you have the You can also have, and one of the things that can cause valvular damage, apart from stasis, is trauma or occlusion. These are the other things that can also cause stasis. So the main thing that you need to know about venous thrombi is that it causes stasis, whereas for the arterial thrombi, it's atherosclerosis. Another thing again is how the clot forms. The venous thrombi, they grow with the flow, and the arterial thrombus actually grows against the flow in a retrograde fashion. And it has to do with where you have the highest degree of turbulence. I already mentioned about the prominent lines of Zahn. You see that in an arterial thrombus. Okay? With the venous thrombus, because you have stasis, you have congestion, you have a lot of blood there. The fibrin and the fibrin and the platelets are not that visible because you have this overwhelming amount of, because there's a lot of blood there. So it tends to look more reddish. You don't see the lines of Zahn as apparent as you would see it in the arterial thrombus. So you can find lines of Zahn, but they're not as prominent. They're usually referred to as a red thrombus. And then with venous thrombi, because so when you talk about arterial thrombi, I'm just referring mainly to the aortic and also the cardiac ones. They tend to be non-occlusive because of, they can be totally occlusive, but they tend to be more non-occlusive. In other words, they don't always completely cover the, especially where you have the larger vessels, because of the force of the blood that is passing through there. For the venous thrombi, because they tend to occur more slowly, they almost always cause occlusion. So, for venous thrombi, more than 90% tend to form in the lower extremities, the legs and the feet, particularly where you have the femoral vein. We talked a lot about it when we, yesterday. Okay. And with venous thrombi, with the congestion, you have the increase in hydrostatic pressure, so you have edema accompanying it. And so usually you'd see that the patient has a swollen leg. From the point where you have that occlusion, you now have the leg is swollen, it's reddened, it's tender. And that's the reason why it's reddened is just because of the congestion. And because it's, the pressure, hydrostatic pressure is increased, and then you have leakage of fluid, so that's why it's also swollen. Okay, and then remember that when it's congested like that, it's still, because it's carrying deoxygenated blood, it's not, that place isn't well vascular, not well, you don't have well oxygenated, and so it starts to create, the patient starts to have some form of pain. It tends to be very tender. Sometimes they're predisposed to inflammation, and that's what you refer to as a thrombophlebitis. Phlebitis is inflammation of the vein. Thrombophlebitis is just saying that it's due to a thrombus. And what eventually happens is that it creates this long cast, and from there, it's easy for the thrombus to break off from the vein, and then, so if a thrombus breaks up from the vein, where is it likely to go? If it breaks up from the leg vein, where is it likely to go? The lungs. Why? I'm not saying you're wrong. It's just, so it's carrying blood to the heart. So you're correct. So I'm just trying to say, okay, fine, it's lungs, but how? Why? Do you have a question? It varies. It varies. The different clinical scenarios. There are cases where normally it can happen over the few days. It just depends on, first of all, we're going to talk a little bit more about, are you talking about to occlude the vessel or just to develop? To occlude the vessel, it varies. It really varies. There are a lot of other factors come into play. The size of the vessel. If it's a large femoral vein, you can also have the other smaller veins that, you can have occlusion. And then a lot of other factors depend on the person. If the person is immobilized, if the person is walking around, you're likely to, if you already have issues with your your venous supply, right? If you're walking around, it's going to be less likely compared to if somebody is completely immobilized and you have that. So you have the compounded problem of the stasis and things like that. And then there are other factors about the individual itself that plays a role. So there really isn't any time that you'd say, you know, sometimes what would happen is this thing might be going over a short time and it's been progressing gradually. And sometimes what you can have is you can have a thrombus, get released from the vein, just a little bit, go to the lung, because when you talk about an embolus, you're saying that the thrombus has detached, and then you have a little bit that goes to the lung. And so a little bit can get detached. As long as the mechanism that caused it is still there, it can still allow it to, you know, so sometimes you can have complete occlusion before you have an embolus. Sometimes you can have an embolus when it's not even completely occluded. So there really isn't any exact time frame when it develops, okay? So when you have the aorta and the cardiac, so when you're referring to, like, you know, within the myocardium, within the heart, where you talk about the valves, it tends to be non-occlusive because of the rapid flow blood supply. But by the time you start going to where the arteries start breaking, where you move from the aorta and you start going into the smaller arteries and stuff, that's where you can have a tiny one lodge, maybe in the kidney, one of the renal arteries or something, like where you have the end arteries, and those ones are almost always occlusive. So it's the aorta and the cardiac thrombi that are usually non-occlusive. I'm not saying that all arterial thrombi are non-occlusive. So when you have the smaller ones where they break up into thinner blood vessels, those are the ones that are most likely to occlude. And because the arteries are supplying blood to different parts of the body, that's when you tend to have infarction distal to where you had the blockage. And the individual starts feeling pale, cold. Remember, it's not supplying blood there, so that's why it tends to be cold and pale and also painful. And the common areas where you have, when it comes to arterial thrombi, the ones that are really of significance, the coronary one where you talk about myocardial infarction, or cerebral when you talk about stroke. But you also can have femoral arteries, but it's usually more common to have in the femoral veins. So let's look at some examples of thrombi. This is a mural thrombus that you have. Mural just means it's on the wall. So it's on the wall of the aorta. And so that's basically, so this is the aorta. This is actually the heart that was being cut open. And so you have the thrombus forming there. For this one, you have a myocardial infarction, and then you have a thrombus forming over. So you had an infarction here, right? And remember what I said about infarction and the way it heals. And so when it heals, it's more likely to create problems for that section of the heart, and you're more likely to have stasis and turbulence in that area, and you have a thrombus forming over there. When it comes to the heart valves, when it comes to the heart, most of the thrombi, a lot of them tend to form on the heart, on the valves themselves. And on the valves, you can have two types. You have the non-bacterial thrombotic endocarditis. These are some of the causes of, some of the causes where you can have thrombus formation there. So what you're basically saying is that this endocarditis is inflammation of the heart and is not caused by infection, okay? So you have a thrombus forming, and that's what you have here. So that's the thrombus forming where you have the heart valve there, okay? And then you have the infective endocarditis, and they are usually often due to Streptococcus species. And then the last one is where you have the systemic lupus, SLE. You can also have a type of endocarditis that is referred to as the varicose endocarditis. Those ones also tend to form vegetations on the heart. So all these three conditions, you can have vegetations on the heart. In the thrombotic one, remember I said a thrombus is a solid mass of blood vessels, so it's going to be mainly where you have the lines of Zahn that I talked about, having the fibrin, and then you also have the platelets and then the red blood cells. With the infective one, what you have is that those vegetations actually contain microorganisms. And so that's more likely to create problems for the patient, because not only do you have the complications from the thrombus, but also the infection. The microorganisms can also, when they detach from there and go somewhere else, they can also initiate, cause infection, and they can actually create more problems for the patient. The varicose ones tend to be more, the varicose endocarditis, SLE, they're more like a platelet, and they have platelets, and they're more like fibrinous vegetations that you have. So this is an example of a deep vein thrombosis. So I'm giving you examples. Remember I said for the thrombosis, I showed you an example of where you can have in the aorta. So this is also the one, most of the thrombosis that you have in the leg, they usually occur in the deep vein. That's why it's referred to as deep vein thrombosis. From the picture, you can see the valve and where they tend to have the thrombus forming. This is actually a picture of the femoral vein, and this is the thrombus, like I said, the solid mass of blood constituents. And this is someone who has thrombosis. How you can tell this is due to a vein, you can see it's congested. It's very, if you look at the size compared to this one, this is definitely larger. The patient will tell you in a lot of pain. So the majority of the thrombus tend to form in deep veins, okay, and these are the ones that tend to embolize. And they're often due to stasis or hypercoagulation states, like I mentioned before. And so when you hear of someone, sometimes you hear have a history of somebody who went on a plane ride, and then a long plane ride, and then shortly after the person had collapsed and had a heart attack, and collapsed and died. It's often due to you having a thrombus forming from the from the deep vein there. You also have we talked about varicose veins yesterday. You can have thrombus starting in varicosities as well, because with varicosities you have stasis again, as I mentioned, and congestion and all that. But these ones really embolize. The ones that really embolize are the ones from the deep vein. So we've talked about localized forms you find in the heart, in the aorta, you find in the leg. There is a condition that is referred to as disseminated intravascular coagulation. And what actually happens is that you have, it's a situation when you have a number of things that can cause it. And what you have is widespread activation of the clotting cascade. And so what happens is that you now have widespread fibrin thrombi in the microcirculation. So not only do you have them on the, like you can see this individual who has multiple ones that you can see on the leg. And then these ones, you have them, and obviously it can occlude and cause gangrene, cause infarction, and ultimately gangrene of the fingers there. So, so you can have them in the brain, the heart, the lungs, the kidneys. And so what initially happens is that certain things, for example, shock, amniotic fluid embolism, malignancies, massive tissue injury or severe trauma. So what they do is they trigger this, you have a number of mechanisms that are triggered, including the coagulation cascade. So what you have is hyperactivity, more or less. And so what happens is that, of course, we know that with thrombosis you have platelets. Platelets play an active role both in the initial, particularly in the initial state, the primary hemostasis, and then when you have the secondary hemostasis. So as more of these platelets are activated, because you have this massive increase in activity of the platelets, coagulation forming everywhere, after a while, it uses up all the platelets. And what happens when you don't have any more platelets? When all the platelets are used up, it's usually referred to as consumptive coagulopathy. And after the platelets are used up, you don't have that. Remember that as the platelets are being used up, or as the platelets are activated, fibrinolysis is also being activated to counteract the effect of the thrombus formation. Remember when we talked about the normal hemostasis, okay? So you have platelet activation, and then after a while you have fibrinolysis coming in to stop the process. So what happens is you have activation of the fibrinolytic mechanisms. Meanwhile, you've exhausted the platelets. And so what happens, you now have excessive bleeding. So they start off by having a lot of clotting, and then this is followed up by a lot of bleeding into the tissues. And the mortality rate can be really high. I just want to throw in here because this is similar. The etiology, there's a syndrome that is known as Trousseau syndrome. It's also known as thrombophlebitis migrans. Migrans means, from the word, it's kind of indicates that it's migrating. Phlebitis is inflammation of the vein. Thrombophlebitis means a thrombus forming in the vein that has caused inflammation of the vein. So with Trousseau syndrome, what is characteristic about it is that you have thrombus formation appearing and reappearing at different sites, changing sites each time. So the reason why it happens is not really known, but it's been linked to pancreatic cancer. And so what happens is that a patient presents with this history where they're having this multiple, and then it may persist for months because it's such at a low level, more like it's not as what you have in DIC. Some have said it's like a kind of milder form of DIC, and that it's the tumor that is triggering these microthrombi that you're finding. If you look at the picture, this is barely discernible. You can't really see that, but the patient would have them at different times, and then they will change up and then occur at another site. And this may persist for months or years. This alone would not necessarily, because it's kind of mild. The important thing I want to stress about this is that it's that when you see this, it's an indication that the person might have some form of underlying malignancy, particularly pancreatic cancer. Okay, so again, you have rapid consumption of platelets and clotting factors here. Okay, so what happens to a thrombus? Depending on what you're dealing with, if you're dealing with an arterial thrombus, if it's in the distal parts like the extremities and all that, or maybe the spleen or the kidney where you have end arteries, you can have infarction. Okay, so you have a blockage of that artery and then you have infarction. And then, but what I want to focus on is the venous thrombus, the fate of the venous thrombus. So you can have venous thrombus, you can have arterial thrombus. One of the things that can happen, I don't know why, sorry, that picture is not coming up on this one. Sorry. That is supposed, is that the same thing in yours? There's supposed to be a big thrombus in the middle of this thing. Is it on yours? I don't know what happened there, so sorry. So basically, what is just showing is a cross-section of what happens in the iliac vein, right? And then the thrombus. So one of the things that can happen, and that happens in majority of the cases, what you have is lysis and resolution. So many times, if every thrombus that developed ended up being of clinical consequence, there will be many more people dead today. So in a number of cases, more than, especially if they're small, in 60 to 80% of cases of really small thrombi, they tend to lyse and resolve and nothing happens and the patient is not even aware. In some cases, if it keeps happening concurrently, depending on the organ, it may create some difficulties. If it's like in the lungs, you may have some issues with breathing if they're just like microthrombi developing, but we'll talk about that a little bit. So one thing is you can have lysis and resolution. The next thing is that you can have organization and recanalization. So organization is just a way that the body kind of is trying to repair itself. So you have, you know, it's more like a healing process. And after that, it's trying to, when it recanalizes, it's trying to open up and create new channels so that you can have reestablished flow. Sometimes when that happens, it's incorporated into part of the vessel wall. But in the cases that end up being of clinical consequences, when this thrombus propagates, in other words, it continues to extend, and eventually a bit of it breaks up, and then it can go to any part of the body, maybe the lungs because we're dealing with venous thrombus, the most likely location is the lung. And so that's why you see in this example, we have venous thrombus to the lung. And this is just an example of an organizing thrombus. And if you see to the picture to the right, the little holes are where it's trying to recanalize, open up new channels so that you can have blood flowing through that place again. So we're going to move on to, oh, it's almost 4. I started a little bit late. Okay, do we take a break now? I still have quite a bit. Can we take a 5-minute break? I know it's hard to ask this time of the afternoon, but let's just take a 5-minute break. Mm-hmm. Huh? I know half of you or 3/4 of you are just busy focused on tomorrow's exam. I can see a lot of activity, and I don't think it's this lecture, but you're robbing Peter to pay Paul. That's what I say, because you take this exam and then in a few weeks you have to take the other one. So, well, let's quickly move on to embolism. So we have a lot to cover with this one. And okay, so what is an embolus? It simply means a detached intravascular mass. So think about the thrombus. I said it's a solid mass that goes and, like occludes a vessel. It forms within a blood vessel. So an embolus simply means one. So thrombus, an embolus is for an example, is a thrombus that has detached and gone and blocked a vessel. So it's located intravascularly. That's the key. And it may be solid, liquid, or gaseous. So it's not only restricted to thrombus. It could be other things. And basically, it's carried from one point to a distant site. And it lodges in the vessel and blocks the lumen. But one thing is important about embolus is that 90% arise from dislodged thrombus. And that's what is referred to as thromboembolism. So when you say thromboembolism, you're just mainly referring to the process where thrombus detaches from a blood vessel and goes and blocks and then and becomes an embolus and goes and blocks somewhere. There are other less important causes, but still important nevertheless: atherosclerotic debris, heart valve vegetation that I just explained, tumor fragments, amniotic fluid, gas, deep sea divers. When they go in, you have increase in negative pressure. The nitrogen tends to dissolve in the body and then is eventually supposed to be excreted through the lungs. But if they come up too rapidly, you have those bubbles released and they can actually go into the joints and the lungs and actually create a lot of problems for the patient, for the person. Foreign particles are mainly with IV drug users, and that's talc. What are the consequences of embolus? Some things you need to note is that where the embolus lodges is more important than the nature of the embolic material. But of course, the exception also is if you have something like an infectious embolus. So if it's derived from microorganisms, it's going to create its own additional complications. But generally, the rule of thumb is that where it lodges, if it goes and blocks a vessel in the lung, is more important than if it goes and blocks something in your little finger, for example. So you also think about the territory that is supplied by the occluded vessel. Okay? If you have dual blood supply, for example, in the lungs, you have the pulmonary arteries and the bronchial arteries. So you are less likely to have the consequences of an embolus is less likely to be as grave if you have dual supply there, compared to if you have just a single end, like when you have end arteries, for example, in the kidney or in the spleen. Also, the presence or absence of collateral blood supply. So sometimes you may not necessarily have that dual blood supply, as you say, but you have a collateral blood supply, like in the heart. Then you can have, the consequences tend to be less. And then the size of the embolus, which kind of makes sense. If it's big, the consequences are more. So what are the types of embolus, types of embolism? There are two main ones, the pulmonary embolism and then the systemic. Systemic mainly refers to arterial. If you remember the blood supply again and how, so you can tend to figure out that the systemic usually refers to the arterial supply. For pulmonary embolism, the most common type is the deep vein thrombosis, as we discussed earlier on. For an embolus to arrive, for you to have an embolus to arrive in the lung and it's coming from an arterial supply, remember we said that the vein is the one that carries blood to the heart. So there must have been something, for example, you had a septal defect that has caused an arteriovenous shunt, and you have mixing of the blood, artery and the vein, and so that's how you can have blood and embolus coming from maybe the artery and ending up in the lungs, for example. So it's very rare. Or the blood must have gone through the lungs, from the lung must have passed through and then gotten to the lungs. Also, the For the systemic embolus, it's usually the left side of the heart and also the major arteries. So I'm going to give you, we're going to see an example shortly. So let's look at pulmonary embolism. The occurrence, you have about 2 cases per 10,000 hospitalizations, and you have approximately about 200,000 deaths. So it's something that is quite significant. About 200,000 people die from pulmonary embolism per year in the United States. And 95% of this develop from venous thrombi. Remember I said what do you call that in the veins? I said when you have the varicose veins, sorry. The varicose veins don't tend to cause emboli, but the ones from the deep veins tend to cause, and so they pass through the right side of the heart, and then to the pulmonary vessels, because they're coming from the blood. They pass through the right side to the pulmonary vessels. They tend to be multiple. So if you have one pulmonary embolism, you're more likely to have subsequent events. And so usually such people are monitored for life. And it's usually from whatever caused it. As long as the underlying cause has not been treated, they're more likely to have subsequent ones. And the clinical effects of pulmonary thrombus are size dependent. I already talked about it some time ago, and I said about 60 to 80% when they're small like that tend to be subclinical. The person is not even aware. They get lysed or organized. If they're greater size and they're not so small, they can cause, depending on where they end up, they can cause acute respiratory or cardiac problems. But when they're really massive, that's when you now have higher risk of fatality. So you have what is referred to as a saddle embolus. I'm going to show you a picture. And what basically happens is that the embolus gets released from the deep vein, travels up, goes through the right chambers of the heart, the atrium and the ventricle, and then gets into the pulmonary arteries. And then where you have the bifurcation, it just goes there and sits on there and blocks it. So what happens? If you have that sudden blockage of the arteries, the pulmonary arteries, you have no supply of oxygen or blood to the lungs. And then what happens after? We're going to see. So that's, remember, blood is coming from where? It's coming from the right heart, right? So the right ventricles and the right atrium and ventricle, they still want to, it's working fine and pumping blood, but you have this dampening effect. So that becomes too much for the heart, and then you have this sudden kind of dilation. And that's what is usually referred to as cor pulmonale, and where you have it's associated with right ventricular heart failure. So these are examples. This is actually the saddle embolus that I just mentioned, and you see it's right here, okay? And just goes and forms, it's coming from here, goes there, and just sits there and blocks it. And in a number of cases before, you still have a high degree of fatality, but there are still some people who have had pulmonary embolism and have survived. When you have this saddle embolus, I've seen cases in autopsy where it most likely will kill the person. And then because I explained to you that you had embolus, you can have thrombus, which is blood. You can have fat. Usually, when you have a fat embolus, it's usually from trauma. You have trauma, you fracture your leg or whatever. What happens is that you have the bone marrow, the fatty marrow. Fat from there gets released, and it tends to be a little more fluid. So those ones tend to actually go farther. You can find them going into the brain and causing confusion or different parts of the body, like the lung here. And the Sudan red is just the stain that you use for that. So fat emboli are mainly due to some form of trauma. So that's, I talked about the pulmonary embolus. When we talked about so I talked about the venous thrombi. So when we talk about the arterial thrombus, where is it coming from and what is happening to it? So most of the thrombus actually come from, 80% actually come from the left side, Okay, so remember the arterial side, blood is coming from the left side and going into the aorta and going to the rest of the body. So, and it can either be from the atrial thrombus within the, and I gave you one of the examples where you can have atrial fibrillation. It can be from a vegetation. We talked about it, maybe infective endocarditis or one that is non-infective. You can have this old myocardial infarct, which is adynamic and causes fibrosis and, it doesn't contract as well. You can have a recent one in the process of healing, when it's still healing and it's not working as well. It can also create problems for the person. So these 80% of the thrombus, the 80% of the embolus that come from the systemic side are mainly due from intracardiac mural thrombi. The rest are from things like the theratomatous plaque. Okay? And when you have this thrombus forming from the systemic side, 75% of it go to the feet. They go there. Remember, they're traveling down. They go travel until they get to a point, depending on the size. So once they get to a size where they can't get through, they block the size. So 75% end up blocking, and so you have gangrene when it takes over the whole foot. 10% is in the brain. It causes cerebral infarct. The remaining, you have a renal or splenic infarct, and also the ischemic bowel. When it causes infarction of a section of the bowel, what's likely to happen? You have perforation, you have peritonitis, you have inflammation. From there, you can have septicemia and all kinds of complications. So it's not just even having just the, because you need the whole section of the bowel for your body to, for the bowel to function properly. So the non-thrombotic embolus, I already talked about them. I said one is fat embolus due to bone fracture. That's the a lot of the cases from that, but you can also have them due to severe burns or extensive soft tissue injury. So in all those cases, what you have breakdown, and then you have fat being released. And what they tend to do is, because like I said, they're so fluid, they can go to different places, go to the lungs, go to the brain, go to the kidneys or the skin and form petechiae. The air is, you also have the air or gas embolism. For the gas embolism, remember the lungs, that's where you're taking in oxygen and expiration and everything. So if you have a compression injury that fractures the chest wall and fractures the lung, you can have air being released into a vessel. But what is really important for us as dentists is that sometimes the air from your surgical hand drill can actually get into a vessel, but that's rare, but it's been documented, and that's why sometimes, especially for the surgeons, they've been advocating that you can not to use air-driven handpieces. Some say use electric, but people still use it. There have been cases where they do root canal therapy, and then you're trying to dry the canal and you're pumping air there, and then you have some cases where you can have that. I talked about the nitrogen bubbles. For amniotic embolism, 1 in about 40,000, but the fatality is high. And what happens is when, during the process of labor and the head engages, for birth, the pressure can actually force amniotic fluid, into the maternal veins, and from there, and so how you would know is an autopsy, you'd see the shed skin cells in whatever organ it has blocked, and can cause respiratory death, respiratory distress. So I just wanted to mention, it's a mimicker, but I won't really say. So this is something that is typically seen with, it's not common, but it does occur with handpieces, and this is when, so what you have is, instead of the air, in some cases you can actually have air going into, remember embolism is air within the vessel, but when you have air tracking within the subcutaneous tissues, it's usually referred to as emphysema. So in this case, especially for the head and neck, it's usually referred SCE, which is subcutaneous cervical emphysema. And then you can see the air just tracking through the buccal space and sometimes to the periorbital region. And it's usually quite common with third molar surgeries. Not quite common, but if it's going to occur, sometimes it's due to surgical intervention or maybe things like root canal therapy. And it's been associated with air turbine-driven surgical handpieces. It's usually a benign condition in most cases. Within 7 to 10 days, the air is reabsorbed, the patient is okay. Usually give antibiotics prophylactically, because what they think, the theory is that if air enters wherever the source of the air is coming from, you may have bacteria from the surface of the skin being forced also into those spaces, and they can create infection. Most times you don't have infection, but you need to keep that in mind and be careful when you're using your handpieces. Remember this case? We did that yesterday. What was this when I gave you the picture yesterday? Does anyone remember? Sorry? Edema. Yeah, periorbital edema. Secondary to what? From the notes yesterday, I mean, you can have different causes. I talked about periorbital edema that can be secondary to if you had like a renal failure, but that would be kind of bilateral. So this was like one eye, and you had that. Even if it's sometimes you can have both eyes, I'm not saying this condition, but this was one I showed you yesterday and had to do with having an anaphylactic reaction. Okay, and so the person has some form of allergy. But if you look at this here, they kind of look similar. And so you might be treating a patient, you get up, and then what do you see? You see that the patient has this swelling of the face, and it can be quite dramatic. Sometimes it can really make the face very, very puffy. How would you differentiate one? One is filled with air, and one is filled with fluid. The one that is filled with air, if you kind of palpate it, it feels like you're popping Rice Krispies, you know how the crackling sound? So that's how it will feel. You kind of feel that because it's air that is in there. But this one is kind of different. And obviously, that's why sometimes when you're going to have a procedure, you ask someone, are you allergic to things, if they're allergic? So that's how you can differentiate. Sometimes there have been cases where a patient presents with this and they think, oh, the person has an allergy. And they start giving steroids and trying to do everything. And meanwhile, the whole point was that it was due to air from the surgical handpiece. And that's why being aware of these things, these different things are important. So I'm quickly going to go into infarction and then shock so that we can hopefully leave here very soon. Any questions so far? Yes, sir? Well, most of the time, sometimes they use them interchangeably, but when the atheroma starts, you start having the lipid layer, and then as it goes on, you have complications, and they can become calcified and things like that. So sometimes when they talk about that atherosclerosis, they're really talking about that progress that really formed, fully formed, as opposed to when it's in the early stage. But to be honest with you, depending on which book you read, a lot of times when people use it, they kind of use it interchangeably. But the most important thing is to remember that either of these things can precipitate thrombus formation. Any other questions? Are you okay? Any questions? Mm-hmm. So I talked about it when we talked about increased cholesterol and having lipid forming on the. So you have increased cholesterol, you have lipid-laden cells. So they line up on the vessels, and over time they create turbulence. You have denudation of the endothelial cells. It exposes the underlying tissue and then triggers the platelet accumulation and all that. And then over time, you can start having complicated plaque, and eventually you can have erosion, you can have thrombus and all kinds of things. You're going to go into, I didn't really want to go into details because you're still going to do that so infarction. What does infarction mean? So by now you should be able to differentiate between what edema is, what congestion is, what hyperemia is, what hemorrhage is, the different types of hemorrhage that you can have. Okay, so how is exsanguination different from an infarction? Okay, what did I say was exsanguination yesterday? So it really refers to death by losing a lot of blood. And the situation that most likely causes sometimes when you have this sudden, you have an aortic aneurysm and it suddenly ruptures and you have this massive blood loss. So always remember that it's tied to that. Okay, well, infarction, what infarction is actually ischemic death. Is also, but when we're saying death, we're talking about, we're more or less referring to a particular tissue or organ. We're not necessarily referring to the person as an individual. So you have ischemic death or necrosis of tissue within the living body. The person is alive. It's mostly due to total vascular occlusion of vascular supply, but it can also be partial, particularly if you have other issues that have compromised blood supply in that area. So some of the facts that you need to know about infarction is the most common sites. The most common sites where you have infarction are the places where you need oxygen the most, that blood supply. And what would that be? That would be the heart, that would be the brain. Those are the two main places. Okay? 40% of deaths in the US are thought to be related to cardiovascular disease, and you end up with a myocardial infarction. In other places like the spleen, the lung, the bowel, the distal extremities, these are a lot of places where, these are other places where you can also have infarcts, and depending on what the blood supply, you can have the different types of infarcts I'm going to talk about in a minute. The most common cause of an infarct is either an arterial thrombosis or arterial embolism. So it's either you have a thrombus that blocks the blood supply, or that thrombus detaches, forms an embolus, and goes to block somewhere else. You have also arteriomatous plaques, or certain things. If you have a tumor that blocks a blood vessel or compresses it, or you have torsion of the testes or ovary, or torsion of the intestines, okay, the bowel, you can also have an infarct forming. For venous obstruction, when you talk about infarcts due to venous supply, most times it's mainly due to congestion. That's how it eventually leads to infarction, because you have that, even though the artery is still supplying blood, the blood there, it's overwhelmed by the congestion that you have there. So what are the factors that influence the development of an infarct? Just thinking about it, the anatomy of the vascular supply. If there's an alternative blood supply, then the chances are that that alternative blood supply, for example, if you have the coronary arteries and you have blockage of a coronary artery, the collateral circulation kicks in, and then that in some cases can also kind of help. So it depends on whether you have an alternative blood supply in terms of having that collateral circulation, or it's even a dual supply like you have in the lungs or you have in the liver and elsewhere. But in places where you have that, where there is no collateral or dual supply, those are the places that are more susceptible, like the spleen, the kidney, or for example the retina. And if that happens, it leads to blindness. The rate of occlusion, if it's slow, it's less likely to cause an infarction. For example, if it's gradually occurring in the heart has enough time to develop an alternative blood supply. It's when it's sudden that you don't have that chance, and then you have myocardial infarction taking over. I just mentioned our tissue vulnerability to ischemia because of the differing metabolic needs. The brain is the most sensitive. If you occlude loss of blood supply to the brain within 3 to 4 minutes, you have death of the cerebral neurons. Myocardial infarction can take up to 20 to 30 minutes, but other organs or other tissues like fibroblasts can last up to several hours. So another factor that can influence the development of an infarct is if you already have a pre-existing condition like a low blood oxygen. For example, patients who are anemic already, they have a low oxygen. Because they're anemic, their oxygen content is lower. Or people who have things like sickle cell anemia or other conditions, or they're cyanotic for one reason or the other, these people are more likely to develop an infarct than others. So what are the types of infarcts? They're usually classified based on the color and sometimes on the presence or absence of microbial infection. A lot of times they tend to use color. The red ones are when you have venous occlusion. Remember I talked about for venous occlusion you have congestion and things like that, so it tends to be more red. And then in places where you have like the lung is spongy and you have this dual supply and things like that, so it tends to be, because if one is blocked, even if it eventually overwhelms that part of the tissue, ultimately the infarct is usually red. Or there's prior congestion, which would go with the venous occlusion. For the white infarcts, they tend to be arterial. And you tend to find them in solid organs that don't have an alternative supply, like the heart, the spleen, or the kidney. The other thing I'd say before I give you a few examples are that most of the time when you have an infarct, what it does is that it elicits an inflammatory reaction. So the first thing that happens is that one of the first things that happen usually over the course of more than 24 hours, within the next 24 to 48 hours, is that you tend to have inflammation around. So the blood vessels and the tissues around there start to react to this dead tissue and start to send cells and initiate an inflammatory reaction to try and mop up the central place where you have infarction. For infarction, remember I said it's due to, the important thing about infarction is that it's due to, it's death of a tissue due to compromised blood supply. Not any other reason. It has to be tied to the blood supply. And so basically what is usually the type of necrosis is referred to as coagulative necrosis. Did you do that with? So what happens is that you still maintain the kind of architecture and you have these ghost cells. Then eventually the infarcts heal by fibrosis. But with brain, what you have is liquefactive necrosis, and at the end of the day, the tissue, because the brain is so effective at mopping up and clearing up the place, what you have is you end up having a fluid filled or cyst filled space. So the shape of infarcts would vary depending on the territory of perfusion of the occluded vessel. In the lung, typically they are referred to as wedge-shaped. In the kidney, you tend to have a triangular infarct. For the spleen, it's kind of less irregular because of the pattern of the blood supply. And then in the brain, what you have is a fluid-filled cyst. Gangrene is just when you have infarction that involves a bulk of tissue, like a limb, or maybe you say the toes, as opposed to like a smaller part of the tissue. And what's important to note about the gangrene is that you can have two types. You have the wet one, which is usually sterile, and you don't have associated infection with it. But for the wet gangrene is when, because it's been exposed, it's now superimposed. You have superimposed bacterial infection, and you can have an overwhelming sepsis. So if someone has a wet gangrene, person is more likely to die compared to from that because of the overwhelming sepsis that is associated with it, compared to if somebody has. So if you must have gangrene, have the dry one rather than the wet one. That's what I'm saying. Okay, so let's look at the stages. I know there's a lot to take in today. I started slow yesterday because I really wanted to try and explain about blood vessels and things, but really the time is short to try and pack in kind of, everything. I'm trying my best to make sure I touch on everything. But once we finish infarction, we're going to go into shock, and then if there are any questions, and hopefully go through the questions from yesterday if we can. So when you look at the stages of infarction, when it's less than 6 hours, there's usually no visible change on when you look at it grossly. The histological changes, you can't even perceive them using the ordinary light microscope, except you use electron microscopy, then you start seeing initial early changes where you have swollen mitochondria. But within 28 to 48 hours, you start seeing pallor. So in this one, you can see the area of infarct where you have that pallor, the pale area, okay, which is where you have that necrosis going on. Then around it, where you have this red that looks a little darker red, that's the hyperemic rim. And it's because of the tissues around here that have stimulated a reaction to try and contain this inflammation or this abnormality here and try and resolve it. So you have normally, of course, when you have inflammation, the first set of cells that arrive there, what you have, tend to have the polymorphs, okay? And then later you have macrophages. So that's part of the innate immunity, and later they can trigger the adaptive immunity and stuff like that. So basically, so that's what's happening. And then with polymorphs, when you say pus is it's just a collection of dead and dying neutrophils. That's what pus really is under the microscope. So you just see this. So that's what you have the polymorphs active and the hyperemia going on there. So that's a typical example of what happens within 24 to 48 hours. Then in the weeks, there are actually different stages. What happens from day this to that, but I really think that at this stage there really isn't a point. You're not going to be treating someone who has infection. You're not, general pathologist. So I'm just going to tell you over the course of several days to weeks, when the inflammatory cells move in, the phagocytose, the dead cells, the cells that have died as a result of the infection, they're being removed by the macrophages, and you have replacement by fibrous tissue. And so that's basically what you have here. You have changes going on here. Sometimes when you have infection and it affects some blood vessels, it damages the walls, they rupture, release the blood there. So you have focal areas of hemorrhage. And so that's why sometimes you can have this mottled appearance where it looks like you have a mixture of some red, and so it has this variegated appearance. This is the one that is an early healing infarct, and it kind of has this gelatinous appearance. And then this is one that has completely healed, and you can see it's really white. So if it's white, we just talked about red and white infarcts. Okay? Anyway, so what's your question?
My question was, the last slide, was that said it was pus?
Which one?
The previous slide where the tissue was actually...
No, I'm saying that it's pale, so it's because it's lost the... I mean, you have infection, you have loss of blood supply. But I'm not saying that is pus. That's not pus. But what I'm saying is that when the neutrophils start moving in, if the neutrophils are to such an extent, you can have pockets of areas depending on how, particularly if you have infection setting, you can have areas of pus. But what I was trying to explain to you is that neutrophils, pus just means collection of dead and dying cells. But the pallor that you saw there is due to the loss of blood supply in that area.
So at which point is it considered coagulative?
Coagulative just simply means what? It's referred to, it's a type of necrosis, so it's dead, right?
Yeah.
So the form that is usually kept is just within the first couple of days or so, and then afterwards...
So coagulative necrosis is just at the very beginning of necrosis.
Afterwards, you don't, yes. So it's not something that is permanent, no. It just happens initially, right? But as the thing, because eventually this tissue is going to be replaced by fibrosis, and that's what you're seeing here. So coagulative is just like the initial stages. So when we talk about, so we have an infarct here. You have the spleen, and you see like a white infarct. So it means most likely it has a single blood supply there, end artery type of thing. Lung, you see, this is an example of this is when they refer to it and they say, oh, it's wedge shaped. Okay. And for the lung, you see that it's kind of reddish. And the reason it's reddish is because it has, I told you that the red infarcts tend to have more than one blood supply. For the brain, you can see later on, with all the necrosis that has gone on, if this was caught at a later stage, you see that what you just see is an empty space there that you just have fluid collecting in it. So the body just takes care of it so completely that it just mops up the entire place and leaves an empty space. For the kidney infarct, they tend to refer to it as triangular, but it's not like you'd see it totally, but it's kind of like, okay, it goes this way and that way, and this is a little bit more like that, okay? And when it heals, finally, you have scarring. With scarring, you have contraction, and that's why you see that demarcation, how there is a central area of depression. In the heart, you also have this in the left ventricle. So this is one that involves the full thickness. This is the one that involves the subendocardial zone. If you remember your physiology or whatever, the subendocardial zone is where it's referred to as the watershed zone, where you have supply of blood from the coronary arteries and then from diffusion within the ventricle. And so if anything causes a drop in blood supply there, that area is the place that is most vulnerable. And that's why you're seeing it affecting this place, because it relies on blood supply from here or here. And if anything compromises it, these places kind of remain okay, but then you now have this thing right in the deep myocardium. One of the complications, it can rupture. Remember, when it's healing, it forms fibrosis. It doesn't contract as well. It thins out. You can have rupture. You can have an aneurysm. And this is just simply a case that shows blood in the sac. When the blood is there, it constricts the heart, and the heart can't move as well, and you have cardiac tamponade. So these are just some of the risk factors for myocardial infarction that I'm sure most of you are already aware of, and I'm guilty of some of them. Okay, so let's move to the last section, which is shock. Do you have any questions as of now? Any questions? I think morning classes are better. Do you agree? Yeah, I can see there's a huge difference between yesterday and today. I know. I don't know why they will put a 2-hour lecture at the end of the day. It's a struggle for me as well, so. Okay, so let's wrap up with shock. What is shock? It's just a word for saying that there's generalized tissue hypoperfusion. In other words, you have reduced blood supply to the tissues that is generalized and affects most parts of the body. So, like I said, it means insufficient blood flow throughout the body. The main thing about shock that you need to take home is that they tend to be life-threatening, because you have reduced blood supply to the lung, to the brain, to the heart, to everywhere. You know, eventually you have these organs start to pack up one by one, and eventually it can cause death of the individual. So this is something I put up just to kind of explain a little bit. I tend to be more visual. I try to use diagrams as much as I can, because for me it's easier for me to remember them, you know, when I have that picture in my mind. But there are many things that can cause shock. And these are some of them: overwhelming infection or infection, sepsis, severe burns, myocardial infarction, pulmonary embolism, exsanguination, or extensive trauma. This is not an exhaustive list, but I just put it out there. But what you need to know is that regardless of what the etiology is, what happens is that through various mechanisms, they eventually cause a reduced cardiac output and or a reduced circulating blood volume. And that is really what shock is. So in shock, you have reduced cardiac output and or reduced circulating blood volume. So, and that's why you have that systemic hypoperfusion. There are different stages. You have the initial stage, which is reversible. Progressive is still reversible. By the time it goes on for a long time, it becomes irreversible. Okay? With shock, what are the consequences of shock? I mean, or rather, what happens when you have shock? When you have shock, because of the reduced blood supply that is occurring systemically, it then affects the tissues at various local points. So you have impaired tissue points, tissue perfusion at various parts of the body. But with people for this one, for when it's due to sepsis, in addition to that, you tend to have thrombosis, microvascular thrombosis. And so with shock causes either impaired tissue perfusion, or as a result of that you have, not that it causes, but because of the shock you have impaired tissue perfusion, microvascular thrombi, and the end result is cellular hypoxia. So the end result of shock is that you have injury to the tissues as a result of reduced oxygen supply to the tissue. But for the septic one, it's the septic one that tends to have this added element of the microvascular thrombus, and that's why I have this arrow, okay? What are the types of shock? Well, you have so many things can cause shock. I just gave you the different examples. But the three main ones you should remember are these ones: cardiogenic shock, which is due to myocardial, because these are the ones that are most common that you probably encounter. When I mean encounter, as you go on and you're reading about stuff. So you have myocardial infarction, and basically what happens is that with cardiogenic shock, there is failure of the heart to pump. And of course, if the heart doesn't pump, blood is not distributed to the rest of the body. So you have this generalized systemic hypoperfusion, and then it can cause infarction. In hypovolemic shock, what's happening in hypovolemic shock? You have severe blood loss. So there's nothing for the heart to pump. You don't have enough for it to pump. So you still have that generalized state of systemic hypoperfusion, okay? And so cases like if you have excessive loss of fluid, it's going to reduce the blood volume, so you don't have enough to pump. Or if you have hemorrhage where you actually lose that blood, you're not going to have enough to pump. Then you have the third one, which is the septic shock, and that's mainly due to infections. What I just want to highlight here, with the septic shock, you have the bacteria, either the bacteria themselves or the toxins or products that they produce. Like in the gram-negative bacteria, you have the lipopolysaccharide thing, which is a very potent, it's a potent exotoxin, and it's a potent stimulator of inflammation, okay? So it can trigger all kinds of things, and the cytokine cascade, the coagulation cascade, and eventually what you end up with, you get into shock. But if you look at the last paragraph, I just want you to note where it says, so before, people thought, it used to be thought that, the thinking was that if you have shock, it means you must have had overwhelming infection. But studies have shown that sometimes you may have shock and the infection is not general. They might even take a blood sample from the patient and you don't see overwhelming presence of blood. You may not even see it in the system, but you have a heavy load somewhere in some part, or you have something somewhere part of the body. And because sometimes it's not just the sheer volume of the bacteria itself, but the toxins that they produce, so they can also have a lot of deleterious effect. If you look at this, the superantigen, which is the toxic shock syndrome for ladies, if you remember the issue of the tampons and toxic shock syndrome, that's what they're referring to. So you have certain bacteria. For the difference between so for the septic shock, they're mainly due to septic shock is mainly due to microorganisms. Most common is the gram-positive bacteria. Then you have the gram-negative and fungi. Okay. For endotoxic shock, endotoxic is from endotoxin, which is a lipopolysaccharide, and that's what you find in gram-negative bacteria. So this endotoxic shock is referring to shock due to gram-negative bacteria. The toxic shock syndrome is mainly due to strep and staph, and these are gram-positive bacteria. And what they do is that they tend to have these toxins that are referred to as the superantigens. So they stimulate the T cells. From the C cells, they cause them to produce a lot of cytokines and all that. And the cytokines that cause this massive derangement in so many different organs of the body. So I want you to understand the difference between endotoxic shock, toxic shock syndrome, and then just the septic shock. And why I'm saying that is because in the mouth, how many I'm going to wrap up very soon. So let me ask you, how many, in terms of bacterial species, I don't know whether you did that in oral biology, but how many do you have in your, what's the number in the oral cavity? How many do you think we have? Tell me. The number, give me an estimate. In your mouth. Species. I'm not talking of the volume now. I'm talking of the types of bacteria. So I'm not talking about how much. 15? 50? $1? Did you say? Oh my goodness. Did I hear you right? So, there are different studies that have said, but actually we have, before, you know, most of the time how you'd identify bacteria is from what, culturing them. But with the introduction of the DNA and being able to use, what do you call that now? Yeah, it's just skipped my mind. And yeah, you can actually now start identifying species that they couldn't identify before. But the statistics, the conservative estimate is 700. But now you have up to almost 1,000. People are saying it's more like 1,000. Different species. I'm not talking about the volume. And so if you're working in the mouth, remember that you're working in such a contaminated environment. Even within the species, sometimes like I did some work with some people on bacteria in the mouth, and it just showed that just putting your toilet brush, your toothbrush, putting your toothbrush next to where you have your toilet seat, you know when you flush your toilet, the aerosol, some of them get on the toothbrush, and we've actually identified some of the ones you see in your fecal matter right there on your toothbrush. So, but I'll leave that talk for another day. Okay? So because you're working in a very non-sterile environment, so to speak, in the mouth, that's why septic shock, all these ones, the ones that will be most important to you as a dentist will be the septic shock that you need to know. Okay, let's quickly wrap up. I know you're eager to go. These are the other forms: neurogenic, anaphylactic, obstructive, traumatic, hypoadrenal. You just need to know them, but if I'm going to test you, I'm most likely going to ask you on the three major ones that I talked about. Okay, this is a heavy slide. You can digest it later. But all I'm just trying to say is that with shock, you have 3 stages, and you need to be aware of that. You have the early non. So once somebody has been diagnosed as being in shock, it doesn't mean they will die, especially if you're young, you're healthy, you're active, and things like that. A lot of them actually, so the survival rate is better now than it used to be. But this tends to be still reversible. This here you still have, it's still partially reversible, but by the time you get to this stage, even with intervention, it's usually a lost cause. So everything is the important thing is to identify this person is going to shock, institute immediate management. So what happens initially here is that you have reflex compensatory mechanisms. And the whole aim is to try and jumpstart the body to kickstart it, and, you know, so you've had, think of hypovolemic shock, and then you've lost a lot of blood, or the heart is not kicking well. What's going to happen? You have these neurohumoral mechanisms where you have the baroreceptors, the catecholamines, the, release, renin-angiotensin activation. What's it trying to do? Conserve. You have release of sodium you have a retention of sodium and water to increase the blood volume. You have tachycardia, which is increased heart rate. The whole point is to kind of keep it. So initially, it does that job of keeping everything, trying to prevent organ damage. So this is usually reversible. But as it continues, you now start having, over time, widespread tissue hypoperfusion, worsening circulatory and metabolic disturbances. And of course, because the tissue is, you're in a hypoxic state, so you have anaerobic glycolysis kicking in, and then you have lactic acidosis. They cause issues on the blood vessels. You have dilation of the arteries or arterioles, and then Meanwhile, the body is still trying to react. You have tachypnea, which is increased pulse, but it's weak, and then the organs gradually start to fail. But by the time you get here, you have leakage of the lysosomes, and then it affects the heart muscles, the bowel, the lung, the liver, and then so basically by the time you get to the late stage here, you start having necrosis of the different tissues, and that's what really this next slide is about. But just before we go, with the septic shock, which I said was important, what you really need to know about the septic shock, this is an example where they use endotoxic shock. We talk about the PAMP, which is the LPS, which is pathogen-associated molecular pattern. For some of you who have really done microbiology, you know that they are potent stimulators of inflammation, bind to toll-like receptors. So what they basically do is they trigger the inflammatory cells. You have the cytokines and series of things that go on. So eventually what you have is vasodilation, thrombosis, because it also activates the pro-coagulative factors while inhibiting the anti-coagulatory factors. So the end result is multi-organ failure. You have up to, most of the time, why I wanted to stress is that often it starts as a local infection, maybe an abscess or peritonitis or pneumonia. And so this can easily start from the oral cavity, and so you need to be aware of it. The final slide is this one, which is the clinical manifestations. The early change I'm mainly referring to is when it's still reversible. So that includes the initial and the reversible, progressive reversible before you come to late. If you look at here, it's mainly necrosis, necrosis, necrosis. That's what happens here, whether it's in the lung. So that's what you need to remember. In the early change, you have series of activities where like the skin is pale and cold, and you start having low urine output. Some of these things you still find in later stages, but it's over time. But the ultimate thing with the late change is that you have necrosis. Okay, so do you guys want to answer the questions, or do we call it a day? You want to call it a day? Okay, so what I'd advise you to do is find the answers of those questions, right? Okay, so I won't need to explain it afterwards. Okay.
Would you like to answer these questions? I think your mic is still on.